Dear colleagues, good day and good evening wherever you are. My name is Ulla Møller Weinreich. I am a consultant from Aalborg University Hospital in Denmark, working at the Department of Respiratory Diseases, and along with that, I do research especially in COPD. And today I would like to talk to you about the effect of heated humidified high flow oxygen treatment in COPD patients with chronic hypoxic failure, and present to you the results of our 12-month randomized controlled trial. Here you have my disclosure. Now, you may all well be aware that in COPD patients with chronic hypoxic failure, long-term oxygen therapy has been shown to improve survival. Patients are highly symptomatic and suffer from physical impairment even without chronic hypoxic failure. And with chronic hypoxic failure, symptoms are not relieved by long-term oxygen therapy. In chronic hypoxic failure, outcome is poor, especially with concomitant hypercapnic failure, despite the use of long-term oxygen therapy. High flow nasal cannula, for now called HFNC or just high flow, is a treatment modality that's primarily has been established in treatment of acute and critical care settings, but primarily used for treatment of acute hypoxic failure and ventilator weaning. But in the later years, there has been an increasing interest in the use of high flow in patients with chronic respiratory failure. I would like for start to share a bit with you on the pulmonary physiology and the mechanics that's in question in terms of high flow treatment. Now, this treatment modality in chronic care is definitely in its cradle. So we are at the time learning of what is actually the mechanism that's beneficial for the patients. But already back in 2006, Fraser and colleagues would show in patients with COPD and chronic respiratory failure that just in a period of 20 minutes, you could see a significant reduction in transcutaneous CO2 and an increased tidal volume and reduced respiratory rate in patients treated with long-term oxygen therapy in addition to, with high flow in addition to long-term oxygen therapy. And patients that were treated with high flow also had less dyspnea. Weinreich and colleagues took this a bit further. He looked into patients in hospital treated with both high flow, with nasal CPAP and nasal BiPAP. And he found that in all these treatment modalities, you had a reduced work of breathing in the patients with COPD. In patients supported with CPAP and BiPAP, the tidal volume increased while the breathing rate remained constant, and thereby the minute ventilation was not very much affected. But in patients treated with high flow, the tidal volume also increased. However, there was also a decreased breathing rate, and thereby the minute ventilation decreased, which is beneficial to patients with COPD. We can learn a bit more looking at the study that Pisani and colleagues carried out and published in Thorax 2017. Now, it's very important to realize that there is a treatment modality difference in patients treated in, example, an acute and critical care setting and patients treated with chronic hypoxic failure. Often in the acute care settings, at least in intensive care units, you use a closed system, whereas in chronic care, you use an open circuit system. Therefore, the mechanisms behind the effect is probably very much different. But what you can see from this study is that high flow, even with relatively low flow at 20 and 30 liters, reduces the expiratory time in patients. And what I think is one of the key effects on the mechanism is that the diaphragmatic work is ameliorated when using high flow, even as low as at a flow of 20 liters. I think this is actually where you find the key to the mechanistic effect of the treatment, really. Another effect that is evident in these patients is that high flow has an effect on the mucociliary clearance of these patients. The heat and humidity increases the ciliary activity in the lung. In real life, that is done by nasal ventilation. But when as a COPD patient, you are treated with oxygen, the mucus layer totally dries out. Actually, it gets a bit concrete-like. And the viscosity is thereby totally reduced of the mucus layer, and thereby the mucociliary transport is impaired. With heat and humidity, the viscosity of the mucus recovers, and the higher temperature you use, the better you can saturate the inspired air with water. And you need to get to 37 degrees to fully saturate the airflow. I'd like to share with you a small video on the effect of the mucociliary clearance.
The air we breathe contains foreign matter such as dust, bacteria, and pollen. Hair-like cells called cilia, as well as goblet cells, can be found in the lining of the respiratory tract called the respiratory epithelium. Goblet cells secrete viscous mucus that forms a layer to trap foreign material. The wave-like action of the underlying cilia mobilizes the mucus layer, removing the foreign matter and preventing it from entering the lungs.
Another way of showing this, actually looking at what you do when you treat with high flow, is seen in this little video. And you can see the difference just of decreasing the humidity to 90 degrees. When you look at the picture on my left, you can see that the movement of the ciliary move little black dots fairly fast over the screen. Whereas on my right side, you can see that after 15 minutes, there's actually very little ciliary beating and there very little movement of the particles in the airways. Another key question in treatment of COPD and chronic care with high flow is the effect on carbon dioxide. Both Nagata, Bräunlich, and Pisani and colleagues found that in COPD patients, you could reduce the CO2 levels when you treat with high flow in these patients. McKinstry and colleagues looked at transcutaneous CO2 measurements, and he looked at different flow rates, which is interesting. Just on a short term, he could see that in patients treated with flow rates of 30 and 45 minutes, you had a reduced transcutaneous CO2 from 5 till 20 minutes. But at lower flow rates at 15 minutes, you only saw the reduction at 5 and 10 minutes. The best tolerated flow in this group of patients was 30 liters per minute. Now, we have a fairly new study from Onodera and colleagues just published this year that in a 3D print, where they in a 3D print modeled the washout of the anatomical dead space. And they could show too that washout occurs at even low flow rates. And they furthermore confirmed what we saw in the previous slides, that you can increase the exhalation time, which is beneficial to COPD patients. It's one of the problems. I have another small video for you here, where you can see what happens to CO2 in the anatomical dead space at different flow rates. And you can see at the higher flow rates, the more CO2 you wash out of the anatomical dead space. And what you benefit from this is that you reduce the rebreathing of CO2 from the anatomical dead space. Now we're reaching to the clinical outcomes in COPD patients when using high flow treatment. Actually, it has been something looked into for quite some time. Shatila and colleagues looked back in 2004 at patients with severe COPD and oxygen therapy, and saw that it improved the exercise performance and bettered the oxygenation in patients when comparing to patients just treated with long-term oxygen therapy. Serio and colleagues also looked at exercise performance and found that they had significantly longer endurance time and increased oxygen saturation and reduced dyspnea and leg fatigue when undergoing exercise with concomitant high flow treatments. Nagata and colleagues showed just this year that with just 4 hours treatment per night with a flow of 30 to 40 liters, that there was a significant improvement in quality of life, and as we touched upon earlier, also CO2. And also they saw, unfortunately, they saw no difference in EuroQol. Perhaps that's because of the amount of time that the machine was used. That's needed to be answered later. And then we have one long-term study previously, the RAY study, that there was a randomized controlled trial in a mixed population with patients with various obstructive lung diseases. They only used the treatment for 1.6 hours per day, and they saw a reduced time to first exacerbation and a reduced duration of the exacerbation time. Now, there's never been a study of high flow treatment specifically in COPD patients, and that is why we set out to do this randomized controlled trial that I will present to you now. The aim of this study was to investigate the effect of home-based long-term oxygen therapy in conjunction with usual care, including long-term oxygen therapy in patients with very severe COPD and chronic hypoxic failure. Our primary outcome was acute exacerbations of COPD measured in rates, and secondary was hospital admissions, dyspnea, which we measured by the MMRC score, quality of life, CO2, all-cause mortality, and exercise performance in terms of 6-minute walk test. We included 200 patients with very severe COPD. They were all gold 4D, according to the 2017 gold criteria, and had chronic hypoxic failure and were treated with long-term oxygen therapy. The only inclusion criteria was that they had hypoxic failure, which was established by 3 arterial blood gases in stable phase, and the long-term oxygen therapy treatment were to have lasted more than 3 months prior to inclusion. Exclusion criteria were, of course, home NIV treatment, malignant or other terminal diseases other than COPD, and inability to give informed consent. At baseline, patients were comparable, apart from one measure, which was the MMRC score. Patients in the high flow treatment group were significantly more dyspneic than patients in the control arm. We drew arterial blood gases at baseline, whilst patients were on the usual oxygen flow, and the 6-minute walk test was performed on usual oxygen supply, allowing the use of walkers if needed, and otherwise the patient was, as I said, comparable. We did a pilot study that indicated that the optimal comfort and tolerability in our group of patients were at a flow of 20 liters, and that was therefore our aim. The supplementary oxygen only changed if the oxygen saturation was less than 90%, and there were no significant changes in oxygen supply during the study. An arterial puncture was repeated after 30 minutes of treatment with HFNC, and we saw throughout the study, as a matter of fact, a reduction of 0.3 kilopascal in CO2 after the initial high flow treatment, which again I think is due to a clearing of the anatomical dead space. Our aim of temperature was 37 degrees. The high flow treatment was on average used 248 days, 7 hours per day. We aimed at 8 hours per day. The main temperature was 37 degrees. Within the first month, we had, unfortunately, quite a dropout of 14% in the high flow group, and 3% left the study entirely. The rest of the population stayed in the group for observation. By the end of the study, 31% of the HFNC treated patients had left the study compared to 27% of controls. That is comparable with other studies done in these very severely ill patients. As for our main outcome, we saw that the exacerbation rates adjusted for age and gender were significantly lower in the high flow group. Also, when adjusting for the use of HFNC as a continuous variant, a reduction of exacerbation was seen with increased use. The predicted exacerbation rate was 4.8 per patient per year for zero use, compared to 2.9 per year, patient per year after 1 year's use in the average patient that had 3 exacerbations in the previous year, which we can see in the figure I just entered in the screen. When we looked at the crude data for hospital admissions, we had no significant difference. But when we adjusted for the use of HFNC, we saw a predicted admission rate at 1.4 per year for zero use, compared to 1.8 per year for 1 year's use in the average patient with 1 admission in the year prior to study. Now, as I told you, at baseline, our patients with in the HFNC arm had significantly more dyspnea. Fortunately, that corrected pretty soon, as after 3 months treatment with high flow, the patients treated had improved their MMRC score significantly. And from 3 months onwards, the high flow patients had a significantly lower MMRC score compared to controls. After 12 months, the high flow patients were significantly better than the patients in the control arm in terms of 6-minute walk tests. We saw a tendency towards an increased FEV1 in the high flow patients, both at 6 months and 12 months compared to controls, but we never quite reached a significant value. As you can see, we only reached 0.56. In terms of quality of life, patients in the HFNC group over the 12 months, they were stable. But you know, when you do a trial like this, you always fall a bit in love with your data. And one of the things that this study clearly shows is that in the control arm, no matter what we did to these patients, even though we treated them according to guidelines, they degenerated in all measures, also in quality of life. So stabilizing patients, I think, is quite an effort. We could even see that in the treated group, after 6 months, patients had a significantly, clinically significantly better quality of life judged by St. George's Respiratory Questionnaire. And it was mainly symptoms that drove this amelioration. At 12 months, patients in the control arm had clinically significantly deteriorated in quality of life compared to the high flow patients that returned to baseline. There was no difference in all-cause mortality, but we found no association between all-cause mortality and number of exacerbations, and this led us to believe that patients died from everything else that they suffered from. You know, these patients have a number of comorbidities. These data has not been analyzed yet. So in conclusion, in severe COPD with hypoxic failure, 7 hours use of oxygen-enriched high flow supplementary to the usual long-term oxygen treatment reduced the number of exacerbation and also hospitalization when you adjusted for the use. It ameliorated patients' MMRC score significantly. It increased patients' walking distance significantly different compared to controls. Showed a tendency towards amelioration of the patient's lung function. And we saw a significant difference in both quality of life and also CO2 compared to controls. And you can read more about this in the paper that was published this year in the International Journal of COPD, a long-term effect of oxygen-enriched high flow nasal cannula treatment in COPD patients with chronic hypoxic respiratory failure. Now, I would just let you into a little bit of what happened after the study. That's something you rarely see, actually. We looked at our patients after the study and found out that 70% of the patients had stopped the treatment, but whereas 30% continued the treatments. And as you can see, those who continued the treatment, we have been able to follow up for quite some time. Now, a lot of the patients that stopped treatment actually stopped because they died. And what is really nice to know for us, and we're quite happy to be able to show you that, is that 2/3 of the patients actually used the treatment till they died. Oh, sorry about that. If we look at the 30% that continued the treatment, we could see that we actually had 13% that increased the use, and then we had a third that used the modality the equal amount of time compared to while they were in study, whereas 56% reduced the use. But all in all, there was no significant difference in use of the modality after the study. And we presented it this year at the EIS, and you can see the abstract number if you want to look further at the e-poster at the bottom of the screen. Thereby, I would like to thank you for your attention. I would like to thank Fisher and Paykel for able to present the study and the data from colleagues around the world for you. And also, I would like to thank my collaborator, Line Storgård, for helping me with performing this study. Thank you very much. And now I'm happy to answer your questions.